presentations in the end. We are running almost half an hour late. We have online presentations also. So next talk, I would like to call Dr. Apurva Srivastava. He's a consultant vascular surgeon at Sir Ganga Ram Hospital, and he's my very old batchmate. We entered the MBBS same time, and I'm so happy after 23 years, we are sitting here on same podium as a vascular surgeon, so Apurva. And he's going to give actually answers for all those cuts can actually be avoided if you do a good angioplasty. That means really good angioplasty with advances, you can actually keep the same fistula running. Dr. Apurva.
Good morning, everyone. Thank you, Dr. Himanshu, for giving such a nice introduction. And thank you, organizers, Dr. Himanshu, Dr. Mahender, for inviting me for this presentation. And Dr. Mahender is one of my illustrious seniors from BHU. And it is a privilege presenting about my talk over here in front of everyone. So my talk is a bit different, what all we have been talking up till now. So my talk is regarding role of cutting balloon and drug-coated balloon in AVF angioplasty. So as we know, technology keeps on advancing. So coming to the endovascular interventions, numerous endovascular interventions are coming in practice nowadays. And one was the endo-AVF that has been talked in detail by Dr. Robert already. So I'll start my talk, nothing to disclose. So AV fistula stenosis. So all of us who are sitting here practically in our day-to-day life, this is the most common problem that we encounter in CKD patients. And it is very troublesome for the surgeon who has operated, for the nephrologist, and even for the patient also. They keep on spending lots and lots of money. So one proper solution is needed for all these problems. So the most common site of an AV fistula stenosis is juxta-anastomotic, because the reason being that is the area where the flow is most turbulent. So these are the signs of AV axis dysfunction. So we have seen in previous presentations. So a decreased thrill, increased pulsatility, development of collateral veins, upper limb swelling, difficulty in cannulation, prolonged bleeding, abnormal recirculation, low flow in the fistula. So all these should lead us to the suspect that there is a problem with the AV fistula. So we've seen about the surgical options, we've seen about hybrid procedure. Me being a vascular surgeon, we also do a lot of surgeries and hybrid procedures. But since my talk is on endovascular options, so there are multiple options to tackle this kind of a stenosis. And you can see in the image, it is a typical anastomotic stenosis, and plus there are multiple stenosis in the vein also. So we have plain old balloon angioplasty, then we have the cutting balloons, we have scoring balloons, stents. Most of the people have started putting in vasculomimetic stents into the failed fistulas. We have the drug-coated balloon, drug-eluting stents, even covered stents. So numerous endovascular options are available for treating all these stenosis. So why there is a need for newer devices? So venous stenosis is most common cause of dysfunction, and compared with the arterial lesions, venous stenosis are lesser responsive to balloon dilatation. So most common type is juxta-anastomotic stenosis, and there are studies which have reported that 34% of the AVFs will develop a hemodynamically significant juxta-anastomotic stenosis within 3 months of AVF creation. So this is a point to be noted, and most of us do not think about these things. So the current first-line therapy for treatment was percutaneous transvaginal angioplasty with a plain balloon. Recurrent stenosis have been common, with rates of less than 24% patency at 3 years after angioplasty and 23% within 6 months of angioplasty. So alternate strategies are needed, and they include the drug-eluting balloon, cutting balloon, high-pressure balloon. We have a 6-month primary assisted patency rates of approximately 96% with the drug-eluting balloons. So now I'll divide my talk into 2 parts. First, the cutting balloons, and then the drug-coated balloons. So this is how a cutting balloon looks like. It has got 3 or 4 cutting blades or atherotomes which are incorporated into an angioplasty balloon, and these atherotomes are exposed when the cutting balloon is inflated. They disrupt the fibroelastic continuity of the ring of neointimal hyperplasia. So theoretically, it could provide more long-standing primary patency because it creates microsurgical incisions before dilatation, which facilitates dilatation with control and localized damage. So we can see in the images, there are atherotomes and cutting blades. So these are controlled and direct incisions made to the vessel wall, and they dilate the stenosis, and they reduce the neointimal hyperplastic response, which is the main cause for an AV fistula getting stenosed. So this is the mechanics of a cutting balloon. We can see we usually don't overinflate it. We inflate it to the nominal pressure because that is sufficient for cutting in through the stenosis. So these are various devices which are available. This is by Boston Scientific, the flexotome device, and we can see the size of the blade is almost equivalent to the diameter of 2 human hairs placed on top of each other. So now coming to the literature, the first report described for a cutting balloon was by Warwick et al. In a case report. So this was published in Cardiovascular Interventional Radiology Journal. 71-year-old patient with a brachiocephalic fistula, high pressure balloon dilatation failed to open the stenosis. So they used a 3.5 mm coronary cutting balloon, which helped in dilating this stenosis. So you can see in the images the cutting balloon that was used. Then coming to the literature, the various randomized trials that have been done. So this was one of the study. Around 35 patients were randomized to balloon angioplasty and cutting balloon angioplasty, and various parameters were noted. So balloon size used was 5, 6, 7, 8. There were different types of stenosis, different types of fistulas. So what the study concluded was that the primary patency as well as the access primary patency was significantly different in the cutting balloon group. So we can see in this analysis, cutting balloon performed better as compared to the normal balloons for primary patency. So there were significant differences seen in this study, and it seemed to have a better 6 months patency. Then there was a randomized clinical trial of cutting balloon angioplasty versus high pressure balloon angioplasty. This study was done in Singapore, and again a prospective trial, randomized trials. Around 71 patients were randomized to 36 to cutting balloon and 36 to the high pressure balloons, and the 6 months secondary target lesion patency was significantly higher in the cutting balloon group, as we can see in the charts. So cutting balloon again performed better in these studies. Again, the third study, the comparison of cutting balloon with plain balloons in AV fistula stenosis. So this was a meta-analysis of 2-3 studies. So all these data was analyzed, and there were 3 studies which were selected for this study. And again, this meta-analysis of RCTs demonstrated superior clinical efficacy of cutting balloon in maintaining patency of AV fistula at 6 months. Again, another systematic review and meta-analysis. This was a Chinese study. So we can see 3 studies were included, and these were the 3 studies which were included, and the technical success rate was equivalent in both the groups. The clinical success rate was equivalent in both the groups. So cutting balloons, as far as success and clinical technical success is concerned, it is similar to the plain old balloon angioplasty. But when we come to the primary lesion patency rates at 6 months, so we can see in the forest plot that in this study it favored a cutting balloon angioplasty when the patency rates were confirmed. So now coming to the drug-coated balloons. So the basic of a drug-coated balloon is it releases an anti-proliferative agent into the diseased vessel wall. So this drug can deposit, and it has got a minimal systemic release. Paclitaxel is well suited and used most of the cutting balloons, and it also inhibits smooth muscle proliferation and thus prevents neointimal hyperplasia. So this is basically a mechanism of action of a cutting balloon. It has got paclitaxel drug, it has got a urea as a carrier so that it is uniformly distributed throughout the lesion. So this was a latest report which was published in a NEJM, and this is one of the standard journals all over the world, published in 2020. And it was a prospective single-blinded 1:1 randomized trial, around 330 patients. Patients with new or restenotic lesions were eligible. And after high-pressure percutaneous transluminal angioplasty, the participants were randomly assigned to receive a DCB or receive a standard balloon. And then primary patency, target lesion revascularization, they were assessed. And here also we can see in the charts that the effectiveness and safety endpoints within 6 months were significantly better in the drug-eluting balloon group, as well as the secondary endpoints such as target lesion revascularization and reinterventions, they were also lesser in the drug-eluting balloon group. So we can see in the charts, again, the drug-coated balloons performed better when compared to the standard balloon angioplasty. So it was found in this study that drug-coated balloon angioplasty was superior to the standard angioplasty for the treatment of stenotic lesions in AV fistulas in 6 months and 12 months patency rate. Again, this was a systematic, so there are numerous studies. So better is to focus on a systematic review and meta-analysis of all the studies and what they say. So I've tried to include the systemic meta-analysis and the reviews. So this was also another study published in the Journal of Vascular Surgery. 3 studies, 141 patients, DEB compared with the normal balloon angioplasty. And this also concluded that DEB angioplasty was a more effective treatment for AVF stenosis at the juxta-anastomotic site compared with the transluminal angioplasty. So these were the 3 studies which were included, and we can see from the forest plot that all these analysis, the meta-analysis was more in favor of the drug-eluting balloon group as compared to the plain balloons. Again, this was a comparison, another systemic review and meta-analysis. So this was a Chinese study and investigate the safety and efficacy of DCBs and common balloons, and lot of literature was analyzed. So this was a pooled analysis of around 14 studies, and it concluded that compared to the cutting balloons, DCBs as a new endovascular treatment have a higher primary patency rate of target lesions and can delay the occurrence of restenosis. There is no evidence that DCB can increase the mortality of patients. So it has got a good safety profile it can use for AV fistula patients. So this study was a very extensive study which included multiple regions of the world, and one more conclusion of this study was there were regional variations also in the AV fistula dynamics and patency rates when the angioplasty was done. So this is the last trial that I will discuss. So this was published in Journal of Vascular Access in the year 2019, and it was a multi-center randomized blinded control trial of DB versus standard in recurrent native dialysis fistula stenosis. The primary endpoint of this study was late lumen loss in trial area of ultrasound at 6 weeks, 3, 6 and 12 months. So again, we can see from the charts that the late lumen loss was lesser in the drug-coated balloon group and more in the normal balloon group. And when we come to the freedom from re-intervention, so freedom from re-intervention was also better in the drug-coated balloon group as compared to the normal balloon group. So all this extensive research, meta-analysis and studies have indicated that compared to the plain old balloon angioplasty, the newer techniques that are available, I agree that availability is still limited in our country, but drug-coated balloons and cutting balloons, they have performed better in most of the studies. Not all studies, but most of the studies. So this is a short video that I wanted to include. So this was one of our cases recently presented with a failing AV fistula. So see, access is surgeon dependent. It depends on you what access you want to take choice. It may be the brachial artery, maybe radial artery. You can puncture the fistula. You can puncture the femoral vein and come through the groin. So for a central vein stenosis, we usually puncture the basilic vein. So this was the pre-op picture, tight anastomotic stenosis. Distally, everything was good. The cephalic vein was good, and you can see a good cephalic arch draining into the subclavian vein. So initially, we did a plasty with a plain balloon, 560 mm balloon, plastied the anastomotic side and the fistula. So good result, but to prolong the patency of this fistula, if we go according to literature, so I decided to use a drug-coated balloon. So it was a 5 into 150 mm drug-coated balloon, and we can see a good result after the post-DCB venoplasty. So I expect that the patency that I will see in this fistula, maybe after 6 months or 12 months, will be much better if I had done only a plain balloon angioplasty. So this was the same patient. We can see a pre-op Doppler and the post-op Doppler. So pre-op Doppler, you can see on the top. So good vein here, but after this branch tributary joins, you can see the vein is completely closed off. So this was the same patient that we discussed. So this was the post-op Doppler of the same patient. And you can see after the tributary that has joined. So there is some perivenous hematoma, but patency is still there. The vein is functioning, there is a good thrill. So post-operative, there was a good thrill in this patient. And we have our own cath lab, and we get the ultrasound prepared in all our cases. So I'll end my talk with the take-home message that gold standard treatment with most of us still remains the use of balloon angioplasty. High pressure balloon is preferred. So compared with the plain balloon angioplasty, newer devices including the cutting balloons and drug-coated balloons have higher primary patency rates of target lesions at 6 months and 12 months, and they can delay the occurrence of restenosis in these patients. So they can prolong the life of the AV fistula in these patients. However, the availability of devices is limited, and there are certain cost issues in our country, and still more extensive research and long duration follow-up studies are needed, including head-to-head comparison to form a consensus. So you have to choose the option very wisely for your patient, because your patient is going to come back to you throughout his life. So you have to choose very wisely while doing your intervention. So this is our hospital, and this is our hybrid vascular cath lab, and recently we've got a new cath lab added to our inventory, and this is our team of vascular surgeons at Sir Ganga Ram